Hi everyone, this is Professor Williamson. This is your lecture for chapter 17, which relates to the urinary system. This presentation is not a substitute for what's in the textbook chapter. This presentation is a supplement, and you also have the ability to utilize the text document, which does not have the audio portion. If you review the textbook information, you note that they start out with the functions and then the organization of the urinary system. Per your textbook authors, the urinary system has two major organs called the kidneys. They're identifying each kidney as a major organ. The word major is an important part in that statement. Yes, the urinary system has other organs, but these two elements called the kidneys are being identified as the two major organs of your system, of the urinary system. Additionally, your urinary system has your uterus, your bladder, and your urethra. The adrenal glands, which are noted here on the top of each kidney, are anatomically part of the endocrine system. So if we look at the two major organs as noted by your textbook authors, each kidney, individually, a kidney is shaped like a bean. It's about the size of your fist. It's located in your back. Anatomically, typically they measure between 10 to 12 centimeters long. Kidneys are covered by something called a renal capsule. Which is a type of fibrous connective tissue. On the surface of each kidney is fat to cushion the kidneys. And anatomically, again, they're located at the rear of your abdominal cavity, which is going towards your back. If you're thinking of it from your personal, how your body is sitting, so to speak, in a chair. The kidneys are also referred to as being retroperitoneal, which means they lie beyond the peritoneum. If we look at the internal structure of a kidney itself, it does have internal components. There are three major regions inside of a kidney. So this picture here is a cross section. If we were taking a kidney from a cadaver and slicing it in half, we would be looking at internal structures. The three major regions of the kidney are the cortex, the medulla, and the pelvis. So the cortex is this inner area inside. Then the medulla goes a little further in if we're going in from the outside in. And then the renal pelvis is this area that kind of attaches it structurally, anatomically located into the ureter. And you can note that the tissue inside of the kidney is different, looks differently. As noted here in this picture, you have some tissue that's of a different character, so to speak. Your outer layer is more granulated. We're talking about the cortex layer. The inner layer of the tissue is more striated, which means it's more straw-like. And then you have something called pyramid-shaped tissue, which is also known as the renal pyramids. From an anatomical standpoint, the blood flow to your kidneys is via the renal arteries. They normally arise off your abdominal aorta. Then coming off of each kidney is a ureter. This is a tube-like structure. This is where the urine drains down into your to eventually go out of your body. Your uterus are typically 10 inches long. They are like I said, a tube-like structure, but they are muscle in the sense. That's how the fluid, the urine, moves down into your bladder. This is again a cross section like our kidney. This is a cross section view of the bladder. So you have the two ureters coming into this structure called the bladder. Your bladder is a hollow muscular organ. It is elastic, sits on the pelvic floor. It grows and expands. As you accumulate urine, it gets bigger, and then when you urinate, it becomes smaller. Typically, your urine can hold approximately 17 to 18 ounces of urine. But typically, once you get anywhere between 150 to 200 milliliters is when you feel like you have to go to the bathroom. If your bladder is typically half full, that means you have a full bladder, typically. You have something called a urethral sphincter, which is down here at the bottom of your bladder. You also have this part that's called the pterygon. Often, sometimes you'll see if a patient has bladder cancer, once they go in and look at the bladder, they'll talk about internal structures, and they say they may see some type of cells in the pterygon. They're talking about this kind of like almost funnel shaped inside of the bladder itself. And then coming out of the bladder, how we actually urinate is through another muscular tube called a urethra. In females, the urethra is much shorter. In males, it's longer. Typically in a female, it's 1.5 inches. A male can be up to 8 inches long. Because of the shorter urethra in a woman, that typically is one reason why women go to the bathroom more often, and also why women have a tendency to get more urinary tract infections. The most common bacteria for a UTI is E. coli, which comes out of your large intestines. So that's the anatomy of the urinary system. Again, per your textbook authors, the two major organs are called kidneys, which cleanse the blood and form urine. So if we then look at the actual coding component, the first thing we're going to look at is the common root operation. So there's a lot of tubular body parts in the urinary system, so that there equates to us looking at some of the common root operations that focus on tubular body parts such as dilation, occlusion, and restriction. Additionally, when we get involved in some of these more complex bladder surgeries, for example, cancer surgeries, we do have the ability to code bypass. There is a surgery where a patient's bladder is removed because of bladder cancer, and they take some of the patient's colon and they make a new bladder. That would be considered a bypass type surgery. We have change, destruction, division, drainage, excision, extirpation, extraction, fragmentation, insertion, and inspection. Again, all of this is dependent on your clinical documentation. These are just some ideas for you to think about. You don't need to memorize the common root operations for the urinary system. But you would need to understand that you do have a lot of tubular body parts, such as your urethra and your ureters, in this system. Additionally, in your textbook, they talk about two specific procedures that, again, would be slightly more complex when the surgeon is creating a new opening, which is typically a temporary measure for a patient to urinate outside of their body without going through the normal route that we just talked about in terms of anatomy. So we have these two ostomy type procedures, like we talked about a colostomy, where a patient is defecating outside of their body. Now, a colostomy can be a long-term type of thing, but these, a ureterostomy, for example, where we're going to give the patient a new pathway to urinate, could be a temporary measure because the patient has some major reconstruction. Typically, you'll see these procedures most often um, with congenital defects. So they're going to be creating some new anatomical internal urinary structures, or they're going to fix them. You also could see these in terms of really severe injury, like a trauma, if the patient was crushed or something like that. But typically, these urerostomies or these ostomy type procedures are not going to be something that's going to be permanent, but it could be possible. But typically, they are temporary procedures. We also will see urinary diversion procedures, which are going to reverse these, obviously. So again, if they're temporary, there's an idea that they're going to then have them reverse at some point, and that would be the repair, would be the root operation. We also can talk about bladder suspension procedures. For those, it depends on how it's done. Again, nothing in coding is absolute. So if a patient is having a bladder suspension procedure, it could be repositioned because they're putting the bladder back in its right anatomical location. Or if they're going to use some type of man-made material such as mesh to facilitate this putting it back in the right position, then the root operation changes to supplement. Also, a more common procedure you'll see is placement of a urinary catheter. If a patient is going to have surgery, especially under general anesthesia, or for a variety of other reasons, they're going to place a urinary catheter. And that would equate to the root operation of drainage. If a patient is having a urinary catheter for a long time, so they're in the hospital, it's been in there for a few days, or the patient may have some paralysis and is not able to urinate or doesn't have that feeling of being able to urinate because they don't know when they have to go, they may need to have an irrigation of their catheter because it has gotten clogged. So these are possibilities also in this particular body system. Specifically in your textbook, it highlights coding guideline B6.1c. If a patient is having work done on a device, so they, for example, they have a urinary catheter in their body and it has become clogged, or they have to change it out, we are then going to code that root operation based on what was done to the device, because the device is already in their body and it's not being actually done, the procedure is not being done on a body part, it's being done on a device such as a urinary catheter. Now I want to move to talk a little bit about transplants. You will see commonly in the urinary system, one of the more common procedures will be a kidney transplant. We do kidney transplants from living donors. One thing I want to point out that you typically would not know unless you've had experience with this in terms of coding it or have had someone in your family that has had a kidney transplant. Typically, they do not remove the diseased kidneys of the recipient. So they do the donor person comes in and they don't take their kidney out, one kidney out, and as we know, you can live with just one kidney if you're a healthy individual. So someone is giving away one of their kidneys, and typically at the same, in a cojoining OR, so the ORs are side by side typically, but sometimes they would transport the kidney, but the person donates their kidney, they prepare it, they take it out, they prepare it, and then they place it in the recipient's body, the person who needs this kidney. They typically, again, do not remove these diseased kidneys, and typically they also place it in the front of the patient, right below their stomach, typically. So that's just something you need to know. This is a clinical thing. We could talk all day, we talk in great detail about why they do that, but this is how this procedure is done. So a transplanted kidney typically goes in the front, below the stomach, and the old, or the native, what they call native kidneys, the kidneys that belong to the person that's getting this donation, the kidneys that they were born with, which are diseased, and typically both of them are diseased, they typically just leave them in their body because there's more trauma to the patient surgically to remove them. In some cases, they do have to go in and take out the diseased kidneys, but often they don't. So don't assume that. And if they take them out, that's a whole different root operation. And if they do it in the same surgical event where they're giving the patient a donated kidney and taking out old diseased kidneys, you would have two different root operations. So you're going to put the transplanted kidney is going to go in and you're going to code it with the root operation of transplant. Also, you need to review your clinical documentation. Per ICD-10 PCS coding guidelines, when we look at the body part value in our code, if you go back to chapter 1 and look at what is the definition of body part value, which is your fourth character of your ICD-10 PCS code, it states in chapter 1, the fourth character of the ICD-10 PCS code is for the specific body part involved in the procedure. So if you are given the information that the patient is getting someone's right kidney, that's what the surgeon took out of the donor. They took their right kidney and they're putting it into this recipient's body. You're coding the right kidney. That's the organ that's being touched by the surgeon. Where the surgeon's putting it at in this patient's body really doesn't matter from a coding standpoint. They could be putting it on the right side of their body or the left side of their body. That doesn't reflect our code assignment or change our code assignment. We're still going to code the right kidney because that was what came out of the donor. However, if you aren't given that information, you have no choice but to code it to the location that is being put into the patient's body. So if you are told this patient is receiving a kidney from their sibling, and that's all you're told. You're not told what side of the body it came from of the donor, and you're told it was placed in the patient's left side, the recipient, then you're going to have to code it to the left side because that's all the information you have. And in ICD-10 PCS, we don't have that option of unspecified laterality. But from a clinical documentation improvement standpoint or a CDI standpoint or coding quality, the body part value is supposed to be the value for the organ the physician is working on. And if the physician is placing a kidney into a patient, we need to know, we should know, hopefully not always, because again, it all depends on the documentation, but the best practice would be for the physician to tell us, the surgeon, to tell us if the donated kidney came from the donor's right side or left side. That would be the best case scenario. Then we talk about stones. Kidney stones, bladder stones can also be documented in your clinical information as a calculus or calculi. If they have more than one, it would be calculi. The most common procedure for kidney stones, if the patient seeks medical treatment, sometimes kidney stones are treated without any medical treatment. They tell the patient to drink more water. The patient suffers through it. But sometimes the patient's not passing the stone, it's too large, and they will do something called an ESWL, which is short for extracorporeal shockwave lithotripsy. That procedure is a fragmentation in terms of root operation. That procedure also is not done with any type of incision or any type of puncture into the patient's body. That procedure, by definition, is using sound waves being directed at the patient's body, and sometimes the patient's sitting on in a water bath type situation or sitting on some type of gel to facilitate kind of the reverberation of the shock waves. But the patient's not being cut into in any way. There's no percutaneous, there's no minor incision, there's no major incision. And that is what we would call fragmentation. However, sometimes they do a ESWL and either right after it they do a X-ray or The patient goes home and the patient's still in excruciating pain. And if you've ever had a kidney stone, my understanding is they can be very painful. The patient goes home or is immediately they find out through a radiology procedure that the stones are too big, still too big, that they will not pass out of the patient's body naturally. And then the surgeon has to go in and somehow retrieve the stones. The most common way to do that would be going in with an endoscope, an endoscopy, but they also may have to go in depending on where they are and depending on if the patient has any abdominal adhesions from previous surgery, or if the patient is having blood in their urine, they may need to go in fast as possible, and they'll cut to get in there faster versus a cystoscopy. But they typically could do a cystoscopy, which would be an endoscopic procedure. And then that's going to change our root operation, because now the surgeon is going in to remove the stones, and then the root operation is extirpation. Remember that from a coding standpoint, your root operation is tied to your overall objective. So on that surgical event, if all of this happened in the same surgical session and the patient didn't go home after the lithotripsy, then your root operation is going to be extirpation. You are not going to use fragmentation at all, because the objective when the patient was wheeled into the surgical room, the objective was to get those stones, bladder stones, kidney stones, out of the patient's body. And unfortunately, the ESWL failed, so we don't code it, and we code the cutting into or the going into to retrieve the stones via some type of surgical approach, which would then be extirpation, because now the physician is going in to get the stones that have been broken up. Also, an ESWL, based on this picture here, is also external surgical approach, because the physician or the tech or whoever is overseeing this procedure is not cutting into the patient's body at all. So I gave you two examples here. ESWL of a large bladder stone, your root operation would be fragmentation. You end up with a code of 0TFBXZZ. Same scenario, same idea. Patient has an ESW of bladder stones, but they're too large, and the physician finds that out before the patient leaves the OR. Patient doesn't go home. The physician, very quickly goes in and does a cystoscopy to retrieve those bladder stone fragments. The root operation is extirpation. Code is 0TCB8ZZ, and that is the only code assigned. We do not assign also the 0TF code. Moving on to body part values, your textbook specifically identifies out for you that the kidney pelvis, which is part of your internal structure of a kidney, does have its individual body part value. So if for whatever reason the physician is going in and he's specifically referring to the kidney pelvis, we would be able to identify that in our final ICD-10 PCS code. Same for the bladder neck. I want to go back to show you anatomically. The bladder neck is the bottom, this area down here, going into the urethra. So if the physician, for example, identifies that he's working specifically on the bladder neck, we would be able to identify that specifically in our ICD-10 PCS codes. Of course, your kidneys and your ureter, you have the ability to identify right or left, and we actually don't have the ability to really say unspecified in terms of right or left. So you have to know clinically, the physician has to provide us the laterality. And of course, if we're working on a male patient and the physician is also working on their prostate gland, we do have the ability to identify that, but it is anatomically, the prostate gland is part of the male reproductive system. In terms of a coding tip, if the prefix peri is used, so if the physician says perirenal, for example, meaning around the kidney, we would code it to the kidney. So the patient has a perirenal tumor, for example, and the physician is removing a perirenal tumor, you would code it to removal of a renal tumor. In terms of codes or coding or medical terminology, nephrostomy and polyostomy. A nephrostomy is approaching the kidney through the skin and through the wall. So if for some reason the physician decides that anatomically or whatever is going on with the patient, we go back to the kidney pictures at the very beginning. If instead of going through this route through the natural opening of the patient to look at their urinary structures, and they can go all the way up if they need to with an endoscope, but for whatever reason they decide, based on previous workup, maybe previous radiology films, that the patient has, let's say for example, kidney cancer, and they're going to go straight in from the side. They're not going to go up through the natural opening. They're not going to do an endoscopic approach. That would be a nephrostomy type procedure where they're going in through the side of the patient directly into the kidney, typically, because they know that what they're dealing with is right there in the kidney area. But a lot of, not all, but a lot of your procedures for the urinary system will be done endoscopically, and typically done via a natural opening, which is through the urethra of the male or the female patient. We also have the ability, or they also do use devices in the urinary system. They can do neural stimulators for patients who are having overactive bladder or urinary retention. They can do artificial sphincters. Of course, we already talked about the urinary catheters, which are considered intraluminal devices. Intra, meaning they're going into a lumen, and a lumen is just a fancy word for a tube. Patients also can have urethral and ureteral stents. So if their tubular structures, the ureteral or the urethra, has become narrowed, they could be putting a stent in to open up that area. Intraluminal devices such as stents are used to dilate. They are not drainage devices. The intent is to keep that ureter or urethra open. In addition, they are completely within that lumen or that tubular structure, so they're called intra, I-N-T-R-A, luminal devices. In terms of qualifiers, we do sometimes use the qualifier value, meaning it's not just Z all the time. The most common type of procedure we will use the qualifier value for will be for kidney transplants. You're going to have the ability to identify where this transplant organ came from. Remember, back in, I believe it was chapter 4, it was defined for you what these terms mean, but they are here again. Allogenic, and I just made this bold and different color font just to draw your attention. Allogenic means a patient is getting a kidney from another human being. It could be a person related to them or not. Synogenic means that the kidney donation is coming from a twin sibling. Not just a sibling, specifically a twin, genetically twin sibling. So it has to be an identical twin or a fraternal twin. But if it's just a brother or sister, it would be allogenic. And then there is the ability, though I have never seen one as of yet, for the kidney specifically, there is the ability at this point to code a zooplastic donation, which means it's coming from an animal. We do see zooplastic donations for heart valves, so it's not far out of the realm of possibility, but I have never personally heard of a kidney donation coming from a non-human or an animal to a human being, but it is the ability to capture that in the code if it ever does happen. We also have, of course, if we're doing a procedure and it's identified as a biopsy, patients can have a cystoscopy with a bladder mass biopsy. Then we would, of course, reflect the biopsy component with the X qualifier. And we also, if the patient is having a bypass procedure where they're doing one of those ostomies because the patient has some type of injury or the patient has some type of birth defect and they need to create a temporary way for this patient to urinate, we can also use the qualifier for a bypass identification of where the end of the destination of the bypass went. So this is the end of this presentation. Remember to code the assigned non-graded exercises before working on the lesson graded elements. Also make sure that you spend some time looking at the code building exercises, which are immediately after the text of the chapter, starting with the first one, which is an insertion of a urinary catheter. The second code building exercise is placement of a urethral stent. The third one is a percutaneous endoscopic biopsy of the right renal pelvis. If you have any questions on this presentation, you can inbox me in Canvas or place a post on the forum related to this lesson.